Hey everybody, Karen Anderson here with Aortic Hope for a super special live Q&A with our very popular Dr. Ben Youdelman. So listen,
Good afternoon.
before we get started, do me a favor, click live, click subscribe. This way you're not going to have to remember when we have our live events. You'll get notified automatically. We are going to talk about aortic dissections because even though it's Aortic Disease Awareness Month, it is officially Aortic Dissection or Disease Awareness Week. I don't know. It's also Heart Valve Awareness Week. There's so many things happening this week, but because we know we have Aortic Dissection Awareness Day coming up, I thought this could be our focus. This could be our hyper focus. We can talk about that and maybe pop in a little bit of info about AFib because I think there might be a question or two out there. So why don't we start off with you telling all the newbies a little bit about yourself?
Well, hello, everybody. And Karen, thank you so much. And the team behind the scenes, the robust team behind the scenes who makes all this stuff happen. My name is Ben Youdelman. I'm a heart and aortic surgeon in Brooklyn, New York, where I work at Maimonides Medical Center. And I've been doing aortic surgery for about, 22 years now. And, I've been involved with both the support of patients and families when they're dealing with the emergencies of aortic surgery, support of patients and families just with the diagnosis and everything in between. One of the greatest parts about my job is that, unlike many surgeons who operate on people and then after their work is done and their wounds are healed, they don't see them again, I get the joy of following people for life, hopefully a nice long life. And we really enjoy having a family of aortic patients along with our aortic center team, which includes our vascular surgery attendings, our cardiac and aortic surgery attendings, as well as a very large and robust aortic center team of nurse practitioners, assistants, medical assistants, and secretaries, and a whole bunch of administrative people. And so that's my nutshell of a story. And I've been involved with you, Karen, for what are we on, 7 years now?
Yeah, we're going on 7. Isn't that amazing? Time flies when you're having a really good time.
Doesn't feel more than about 20, really, most days.
Sometimes 5 minutes. But I'm not your patient. You made that abundantly clear. Not going to be. Well, I'm somebody's patient now. That'll be happening soon. We'll talk about that later. But yeah, no, not your patient. Totally okay with that. I'm okay with that. Although I would be honored if you took me as a patient if I needed you. I know that you would do an amazing job. So yeah. And we're going to talk about the bridge walk a little bit too, as I see your green poster behind you, which is great. Yeah, good stuff. Good stuff. Excited about that. All right, let's start off and just talk about the aorta. Let's talk about it because again, it's dissection week. We want to first have to have a good understanding of what the aorta is before we can talk about type A's and B's or 1, 2, 3s or all these different things and what do they mean. And, we'll get into that in greater detail. Oh, look at that. Fancy schmancy.
So the aorta is a large blood vessel that comes out of the body. It usually has these 3 branches on the top. It is the blood vessel that gives rise to all the blood on the arterial system in the entire body. So if you have a problem with the aorta, you got a big problem. It is not the heart, and people sometimes confuse it with the heart. I'm not certain exactly why or how, but it is discretely different, and it is the place where the half of the heart, at least, expels all the blood. And that's one of the most important things about it. It gives rise to every blood vessel in the body, starting with the coronary arteries and going all the way down to where it splits to go into your legs. So it's super, super important, Karen, super important.
Super. We know that it's also the super highway. It's been described as many different things. So the different issues that you can have with your aorta, which doesn't mean you have an aneurysm to have a dissection, but let's just go real quick, briefly through aneurysm. What's an aneurysm?
Okay, so an aneurysm is an aorta that's larger than 99% of the people out there. That size has been defined as 4 centimeters. So
Okay.
if your aorta is larger than 4 centimeters, it's considered an aneurysm. If your physician wants to make you feel better, they'll say things like aortic ectasia or it's a little big. But the medical definition is when you're outside of that normal range, you have an aneurysm. Doesn't mean it's going to become pathologic, but that is what an aneurysm is.
Mm-hmm.
Now, aneurysms occur fundamentally from 2 major sources. One, and the most likely source, is that there's a huge genetic component which has been more and more identified over the last 10 to 20 years. But compared to cancer, it's really at its infancy in terms of identification. And then the other thing that causes aneurysms is very advanced atherosclerotic disease. And that is not always, but often in the belly, where the blood moves a little slower and where atherosclerotic disease of the aorta can develop in a slightly different way. But you can also have aneurysms in the belly that are related to aortic abnormalities from genetic causes as well. And those are the 2 major reasons that people get aneurysms, true aneurysms of the aorta. Now, there are these other things that are a little more confusing, but I don't want to confuse everybody by mentioning a million things.
Okay. Okay. All right. So then let's jump right into what a dissection is. Because this is what we're trying to avoid, right? And we're going to talk a lot about the whole think aorta concept as well, and how all of this has been bridged. I just brought all 3 organizations in, bridged together. So, but let's get right down to the nitty gritty and dirty of what a dissection is.
So a dissection is a tear in the internal layer of the aorta. And sorry, I just have a quick text message. But the internal layer is called the intima, and the external layer is called the adventitia. And the layer in the middle, which is called the media or middle layer, it doesn't really have a lot of structural integrity. So when a tear in the intima occurs, it has one of 3 choices. One, that can be a small tear, and it actually probably can be healed, although we don't really see those, but we assume that that does occur. The second thing that can happen is that blood can go into the wall of the aorta. And then the third thing that can happen, well, I guess there's 4, I apologize. The third thing that can happen is blood can travel through the wall, and that's a dissection. So it's dissecting through the wall, but it breaks back in to the aorta because the adventitia is so strong and pliable that it keeps the pressure of the aorta inside the tube, and the intima has a second tear breaks back in. And that's how a dissection can occur.
Okay. All right. So when people talk about I had type A or type B or type 1, 2, 3, what is all that? What is all that?
Sorry.
Look, you just came out of the OR and now you've got saving things to do.
That's true.
You've important stuff. So type A or B was named after DeBakey, right? Dr. DeBakey.
Yeah. So the Stanford system, so Stanford A and B, was actually coined early on. It's so much easier just to wipe away these conversations about these nomenclature because it gets very complicated. There are basically 2 different types of aortic dissections. One should be repaired immediately because the risk of death from waiting is much larger than the risk of death from the surgery, which is how we make every decision about an operation. And those are the so-called ascending aorta tears, or type A, because they're in the ascending aorta. The other ones occur not in the ascending aorta. They can be in a lot of different places, but they're not in the ascending aorta. And those dissections, when they occur, provided that there's no alteration of blood flow to any of the branches of the aorta, those dissections are treated with medical treatment initially. The aorta goes into a chronic phase after about 2 to 3 weeks, or a subacute phase. And surgery, which is often but not always performed in an endovascular way after, provided there's a problem, which is usually dilation of the aorta. Those are done down the line after blood pressure has been managed. Again, that's because the risk of an open operation and the risk of further problems if an endovascular operation is conducted is greater than the risk of doing nothing, which does carry some risk, but it carries less risk. And that's why the non-ascending aorta dissections are treated non-operatively, provided there's no abnormal blood flow that we refer to as malperfusion.
I love that. I like go away from letters, go away from numbers. It's either ascending or not. I just kind of like that
It
because
makes
it
it
makes
easier
it
to
so much
understand.
easier.
Yeah.
It's so
Yes.
much
But as a
easier to
person
understand.
who constantly is talking to people of varying educational levels, medical students, residents, junior attendings who do other things for a living, not to mention all the patients, simplifying the conversation has actually been the number one thing that has allowed me to be able to communicate with people effectively, because the complexities of what I do is really not necessary to be dumping onto a patient who's scared out of their mind that they're going to die as soon as they see my face, which of course does give me a bit of a complex, I have to tell you, Karen, but I'm getting over it.
I would think it would. Well, you know what? I had a doctor I was interviewing one day that said that probably the biggest contributor to some of the PTSD we see is what happens in the ER when a doctor comes to you and says, okay, you have an aortic dissection and you might die. So decide where you want to be life flighted. It's like, what? It's the worst delivery in the world. Instead of saying, hey, we've got something major, we've got you, but where do you want to go? And we'll get you all the info when we're on our way. You know, just anything but you're probably going to die. So let's get this decision going.
Because the person who's talking to you is just as scared as you
That's right.
are.
That's right. How often do the big hospitals that a lot of people in the community want to talk about, a hospital like yours or Hopkins or Cedar, how often are you guys, your well-known aortic center, for lack of a better word, how often are you guys getting a dissection patient in the ER?
Oh, I mean, we get them probably about, depending on, I was just about to say there is a so-called dissection season, but that's probably a little bit of lore. But we probably see somewhere between 10 and 30 dissections a month. Sort of depends on the type of month we're having and things like that. There are some unbelievable days and weeks and months that come about. But, we many years ago, all of us in New York City got together and talked about at all the hospitals, all this stuff. So there were like between 200 and 250, a month between all of us.
That's
So
right.
there's
And
a
that's the
lot.
people that make it there. And I'm
Correct.
not talking about the people that die at home, but people who think I have bad gas. I
Yeah,
must have pulled a muscle. So, and that's, is that include transfers into or just organic?
it does, but they're all within New York City.
Right, right. Okay. And then, your regional centers are really scared because how often are they seeing people? 1, 2 a year, maybe? I don't know.
Yeah. So the part that's
Yeah.
really the part that you have to walk back to is not necessarily the hospital, because again, hospitals don't take care of people. What the
Right.
physicians do, if you query emergency medicine docs, every emergency medicine doc will see one dissection maybe every other year.
Wow, that's
As
it.
their primary, person that they see
Uh-huh.
walk in, and that is really quite shocking.
Yes.
But if you do the mathematics, you can see why. I mean, there's a lot of emergency medicine docs that do, work in shifts. Oftentimes, they do 3 or 4 12-hour shifts a week, and you can see how even if the hospital gets even 5 a day, let's say, or 5 a week, they can miss it altogether.
Right.
And so
Right.
when they see that patient in front of them, common things being common,
Yeah.
that's not what they think, but that's what the Think Aorta campaign has allowed us all to do, is just think about it. And if you think about it, then maybe you'll go down that pathway, talk to the family, find out if there's a family history of dissection, and help the patients out.
Right. Exactly. Nice segue there. Nice. How you did that. Slip that right in. I want to check in with Josh real quick because I know we're time crunch here a little bit. Who we have with us and if there's questions and chatter going on.
Well, we've got quite a few people in here. The first thing I want to do is address an anonymous question that came in. Can chemo for aggressive breast cancer be safe for me with a type B dissection?
Well, listen, chemo is a very large grab bag of things. And the simple answer is that what physician's job is to make you live as long as possible, given the diagnoses that you have. If the dissection is stable and you've had surgery, and that's not the thing that's impending, and the cancer is now the new thing, then you have to prioritize the cancer. And that's it. So there's I'm not trying to be crass, I'm just telling you how we think. The dissection is not the problem, the cancer is the problem. If the cancer becomes, cured or kept quiescent, and then the dissection becomes a problem and you need a surgery, well, then that's a different conversation. So you have to think about it in terms of sort of the way we think, which is you could say it's kind of a lot of things, but it's just the objectification of the disease, not the person.
Okay, thank you for that, doctor. Let's say hi to please and thank you, Chef Rob, Molly, Tim. Obviously, your buddy Tim showed up for you right away. What up, Tim? Molly, Christina, Terry. This is a big list. Tom.
That's awesome.
Nathalie. Belda, of course.
Have they said anything about my new haircut or no?
Let me see here. Bum, bum, bum. Molly says, so excited to watch the dynamic duo together again. Welcome, Dr. Human. But she was using her voice to text operation, so it didn't pick up Dr. Youdelman. I look forward to meeting you at the Bridge Walk. I'll be flying in from San Diego. I can't wait.
Oh my gosh, how beautiful.
Yeah, Molly's going to be great. Let's see here. Rob says he can't wait to see everybody in the Big Apple.
Oh, that's so nice.
Coming in from Michigan.
Chef Rob's like, Dr. Human, I hope he is. I love autocorrect. And Tim says, sometimes I wonder.
I tell you.
So
as of last tally, we have received 67 emails from the server where people who are registering are signing up. And that's usually somewhere between 2 and 5 people. So
these are excellent
big
numbers.
One.
And
big
Elena
one.
has
I don't know if you
just
can
joined
see
the chat.
this. Those are the shirts.
I love it. I like that color green. So tell everybody a little about this Bridge Walk and how you got it started.
So I can't take credit for the idea, except to say that we were having gatherings at the hospital every maybe 6 weeks with all the patients. And I had been here just for a few months, and I wanted to do something to get people together on a beautiful day. And it sort of became obvious that September was the time to do it, get the kids back to school and then get them up and moving and stuff. We joined forces, with a sort of hopefully was going to be like a countrywide group of people. Pardon me. And I'm going to have to take this. I apologize. Hold on, please.
Holding. what he's going to share with you is information about how the bridge walk, the Aortic Disease Awareness Bridge Walk, came to be, which is part of a grassroots organization that Ben put together called Aortic Bridge. And the walk occurs across the Brooklyn Bridge, which I will be there too, although this chick probably wouldn't make it to the halfway point where the mangoes are, but I would do my very best. Keep going.
Sorry.
Go
So,
ahead, Ben.
so we came up with this idea, and being that we were in Brooklyn and the Brooklyn Bridge is such an absolutely stunning thing, we came up with the Aortic Bridge as our name, and then the logo, which actually I was very proud of. I came up with the idea, and then with Dale Zacketts and his wonderful wife and their company, we got together and came up with the logo, which we've been using right along. The walk has really developed into an annual celebration of life, and I'm incredibly grateful for everybody who participates. And I'll tell you, not everybody who participates is just the patients who were saved. We have patients who died and whose family or have relatives that died, and family, somebody came in and I did surgery on them, and then they subsequently had someone else in the family that had a rupture. I mean, this is a very complicated group of people when you take it as a whole. But the bridge walk is a timestamp where we get together and everybody gets to say, I got through another year and we're going to do this together. And I think it helps everybody to celebrate life when not everybody's always feeling like they want to celebrate, but I think it's great to be together, and it's certainly a beautiful time of year in New York, and walking across the bridge is just a wonderful feeling. You really feel like connected. And this year, we are going to be going down underneath the Brooklyn Bridge to the so-called Dumbo. And my father told me I'm never allowed to say it because it's just a terrible acronym. Down under the Manhattan-Brooklyn overpass, Dumbo. But
So we're not on the top floor.
Well, we're going to walk on the top floor, and then where we're going to eat is going to be right on the ground, directly underneath the bridge.
Oh, you changed locations. I didn't realize.
I did.
Okay.
I changed the location to a wonderful place, and it was kind of fun. When I get there, I met the owner, and then I met his son-in-law, who is the cousin of one of the docs that I work with, and we all sort of connected, and it's going to be really nice.
That's awesome. That's wonderful. Very good. Okay, so getting back to just wrapping up this information here. So when we talk about dissections and we talked about the different types, one of the things I think we should talk about, I know you said how things would be medically managed. When you talk about think aorta, think family, right? Mm-hmm. What are the parameters in which somebody would want to have themselves and or family members genetically tested? Like what goes into the thought process of that? Because I know you've mentioned before certain age of dissection. So let's just talk about that a little bit.
So this is an incredibly complicated topic if you talk about the genetics, which I won't talk about. And probably one of the reasons that I'm very reserved about talking about the genetics is that I think it is at its infancy. Mm-hmm. I think we've sort of proven that. Cancer treatments are now based on the genetics of the cancer. Aortic disease treatments are based on the history of the family and the current history of the patient. Okay. So the treatments are not necessarily based on your diagnosis, because if you carry a gene, but yet you don't exhibit what are called the morphologic features, or the body parts, despite you may be carrying that gene, we're not going to operate on you for a gene. We're only going to operate on you for how that gene expresses itself in you. And there is significant variability, probably because other genes have a mixed effect on the original gene's effect, and therefore there can be what we call partial effects of certain genes, okay? Now, when there were 6 genes, we all talked a lot of trash because we were like really smart, we knew everything. And now that 30 years have gone on since I was in med school, we've become really stupid, which is excellent. And I'm glad we finally realized that we really don't know anything about this stuff. And that some really smart people are trying to figure this out. And until they do figure it out, I am not going to make a big fuss about the genes themselves. So there's my soapbox of that. So let's shift to the family where you have genes and different groups of people from different parts of the world who share genes. It is clear, as so clear in every one of our practices, that there are certain groups of people that are more likely to develop aortic problems and other groups of people that don't. And the truth is that the more mixed families are, the less likely any particular gene is going to express itself consistently. But when you have families where it is clear that there is something bad going on in each generation, great grandma died suddenly and her 3rd child died suddenly, and the second child's first child died suddenly, and on like that. Those kind of very, very strange family histories are often tied to some disease that is usually genetically linked. And since we know that aortic disease is, that's where the Think Aorta, Think family came from. And it really has to do with the basics of risk stratification and the fact that if you have multiple people in the family that have unexplained sudden death, and I do not care what the physician at the time called it, I only care that it happened multiple times in multiple generations. You have bleeds in the brain, you have documented aneurysms in the body, or documented surgery for, let's say, aortic valve disease, which is a secondary effect of the aorta expanding and making more room for a valve to try to stop the blood from going backwards, but it can't because it's too big a space. Those types of things let me know that the person in front of me in my office who's coming to me because they get diagnosed with an aneurysm, that person has a family history and I need to be aware of it and they need to get other people checked out. The other families are the people that just show up and they have an aortic dissection, and I get a CAT scan on them and I look at it and it shows that their aorta is actually barely 4.5 centimeters. I told you 4 was an aneurysm, and now dissected when the aorta rapidly expands by maybe 20 or 25%, they're just above 4. That means that person's aorta dissected less than 4 centimeters. So even if I was seeing them in my office, I wouldn't even know what to do with them. So it begs the question, now what do we do? And the answer is, Karen, that treating high blood pressure is by far the greatest way to prevent or decrease the risk of stroke, heart disease, kidney disease, and aortic problems, right? And it is a relatively easy thing to treat, and it's something that needs to be treated more aggressively in patients who have families with a history of aortic disease. We do not know if it's going to decrease the expansion, but we do know that if you have a tear, and if you have a dissection, and if you have a rupture, or if your aorta is getting larger and there's a problem, any of those problems will be slightly smaller problems if your blood pressure and your heart rate are lower. And I don't want to bring in the calculus thing because I know everybody's going to freak out when you say math, but it is calculus. For the kids listening, that's why you take calculus.
Don't say it never helped you. And I know that a lot of times part of the things that we've talked about is not, like you were saying, not necessarily the specifics of genetics in and of themselves, but rather, even in the least, have your family members treated as though there's could potentially be something there. So having
No harm.
baseline scan, right? Getting somebody
So-
scanned to know there's no harm in that. I mean, I was happy that I had my son scanned at an adult, and now they know. And looking down the road, they'll have something to compare against. Otherwise, I would have never thought to do that.
Yeah. I mean, I tell people they need an echo,
Mm-hmm.
they need an ultrasound of the belly, but the chest, you can't see the aorta behind the lungs without an MRI or a CT. An MRI is very, very, very fuzzy.
Mm-hmm.
Fuzzy means, like back in the day, you wouldn't know this, Karen, because you're so young, but we used to bring our little 110 cameras to a place called Photomat.
Yes, me
They
too.
used to they used to develop our film, and we'd get it back. And in the foreground, we'd see like our friend, and in the background, we'd be like,
Who is that?
who is that? So that's the same thing now,
Yeah.
right? So everything's kind of blurry. Now with the digital camera, same concept. So MRIs are not as good as CT scans, cardiac gated, where they put the EKG electrodes on you,
Mm-hmm.
and the data acquisition is directly related to the EKG, so the heart's not moving as much. These things have all made us able to slightly better pin down the size of a structure that's constantly moving.
Mm-hmm.
So how in the world do I figure this out? Well, the answer is I take measurements over time.
Mm-hmm.
And if it's expanding over time, then I know that, we have to deal with it when you get past 5 centimeters, unless you have other issues.
Right.
Now, the 5 centimeter thing is new. So there may be people out there saying, wait. My doctor had said 5.5 centimeters years ago, and then they switched it to 5. That was a very, very simple thing. We thought that the risk of death from the surgery was 5%. That's what we told everybody for 25, 30 years.
Mm-hmm.
We then analyzed our data back in 2010 and published it I'm sorry, not 2010. We analyzed our data from 10 years in 2021, and we published it in 2022 in the fall. The risk of death from our operations, our ascending aortic operations, was 2 to 3%, which is half of what we thought it was. And so when we let patients walk around out there between 5 and 5.5 centimeters, they were assuming a lot of risk with no real benefit, because we knew that the surgery was now safer than we thought it was. And the sad part, and all of us have these stories, I would have about one patient it was like 2 patients every 3 years, roughly, that we would hear about that died from some event when they were on the waiting list, because the risk of death from surgery we felt was higher than the risk of waiting. And when we got this data that showed that the surgery was actually 2 to 3%, which was a lot of what our own personal data was, but we didn't want to extrapolate for the entire population. Oh, my data is so much safer, blah, blah, blah. I mean, we could do that, but then it wasn't the right thing to do. And then we did it. And I have to say, I haven't had, knocking on the simulated wood finish, I haven't had anybody, die on my list in the last 3 years. So it does make me feel good. But it's not a zero-sum game. So it's a very, very complicated decision. But if you have a family history, and if you know about it, the best thing you can do is get an echo, get a CT scan, get an abdominal ultrasound, and come talk to somebody like me. It doesn't have to be me. It can be, but it doesn't have to be. And then we'll have a conversation. We'll talk about life.
We'll talk about while you're walking across the Brooklyn Bridge. That's what you're going to do. All right, let me check back in with Josh, see if there's any last-minute last-minute conversations, questions, the whole 9 yards before I let you go and finish saving the world. Go ahead, Josh.
Right on. All right, so first question here. Is it possible to have an aortic dissection / aneurysm without having the terrible pain that many people describe and go undetected by the patient?
I don't know. Obviously, if anybody is friendly with any women at all, they'll know that the threshold of pain is completely different. I heard this crazy rumor that sometimes they actually have babies without any pain medication at all. And I think that that's pretty incredible. But pain is an exquisitely complicated and totally personal, subjective thing. So you're asking a question that's unanswerable, but here's what I do know. I've had plenty of people who come in with clear chronic dissections. And when I query them about some things, have you ever been in a car accident? Have you ever had a day when you just had this weird pain? When you have this, usually they can sort of pinpoint some day or some event where they felt kind of weird. Occasionally, they may or may not have had some, shall we say, personal mind-altering experience, liquid or otherwise, that put them in a state where maybe they would not have appreciated the pain, or maybe they wouldn't have known what the pain was. All of these things, those of us in our business have seen all kinds of different stuff. So the answer fundamentally is everything is possible. And people do show up with all kinds of stuff without any real history of pain. Strange, but true.
Yeah.
I'll take that answer. In the chat, Tim says, I had no pain, severe tachycardia, but no pain. Right? So.
Yeah, I mean, it does happen. And it's a very subjective thing. The hard part is there are times when you get people who are incredibly tolerant of pain. They just, I've had people with an acute dissection come in and say they just felt a little weird. And it's kind of remarkable. I'm like, you all right? They're like, yeah, I'm fine. I'm like, you sure? So it is kind of amazing.
Right on. Welcome to the chat, Epicurean MIR. His question is, or her question, what are the top choice BP meds to prevent a dissection?
Oh, my friend. There is no such thing. Okay, so all the medications do the same thing. They just do it in some different ways. And I can't tell you, I'm not smart enough to actually tell you if your blood pressure is lower and your heart rate is low with one medication and it's at the same level with another medication, whether any of them are actually different. I think one of the reasons that there are a bunch of different medications is because all these medications don't work for every person.
Right.
And that is very obvious if you've ever been a person or people that have been people, that they take medications and they have a varying different effect at varying different doses. So it's extremely obvious why different medications were invented. So, but if you took 1,000 people and you got all their blood pressures to 100/60, and they all had a 4-centimeter aneurysm and you followed them for 30 years, you have genetic variability, you have exercise variability, you have food variability, you have weight variability, you have altitude, you have everything under the sun, and you cannot possibly pinpoint a medication as being better or worse for the general population. You can only figure out a medication that's better or worse for you. So that's what you got to do. That's your job.
That's an excellent answer. I like that. Melissa says, 15 years treated exactly as Dr. Y states, no growth and very low BP.
There you go. I mean, women do have a significant advantage over the lifetime, which is that lower blood pressure for women, provided you don't get dizzy and fall down, doesn't really have any major adverse effects. For men, when you get to a certain age, which I'm hoping I never get to, lower blood pressure can cause erectile dysfunction, and erectile dysfunction can have a very dramatic effect on men and women, obviously, in the relationship. And so we do have, these medications like Viagra and Cialis and what have you that do help with erectile dysfunction. But if you just allow your physicians and work with your physicians, and I'm speaking specifically to the men in the group, you can deal with these things. You just have to deal with them straight on and not act like anything's weird or act funny. You just have to talk to people and realize that, you know, we all deal with this stuff all the time. But the minute you start acting weird about medical problems, that's when people stop taking their medication. Then you run into a different problem. And, you know, it's super important. So I appreciate you saying that for 15 years you had your blood pressure nice and low, which is wonderful. And, you know, that's the key. And also when you start the medication, you're going to feel weird. But 2 months later, if you stay on it and you deal with a little bit of slow getting up in the morning and from a seated to a standing position a little slower, your body will get used to the medications and overall your blood pressure will be lower. When you exercise, it's going to go up, which is normal, but the benefit of exercise has been well documented. So we don't really need to explain that, but it just, you know, the other 23 hours a day, it's important that you have slightly lower blood pressure and heart rate.
I like that too. Let's see here. Another question. Does electrical problems, AFib and aflutter and or valve problems, mitral valve prolapse, substantially increase possibility of aortic disease in a Marfan's patient?
I want to thank you for the compliment because clearly you think that I'm really smart. That's so generous of you. The simple answer is I have absolutely no way to figure that out for the general population. I think that the issue in Marfan syndrome clearly is the overriding abnormality of the aortic wall. I think a lot of these other things are secondary. But again, thank you for the compliment. It's very generous. We could talk about, we could drift into the AFib conversation, but I certainly think that probably the number one issue in Marfan syndrome is going to be the aortic wall and all the associated connective tissue issues, joints and eyeballs and things like that.
Fair enough. I like that as well. Melissa wants to echo what you were saying about genetics. Dr. Y, family genetics, maternal and paternal, 3 generations, and only grandmother diagnosed and passed away. All other are handling it with blood pressure monitoring.
Yeah. It's again, you know, whatever your parents had, your grandparents had, that's what you're going to get. So just keep an eye on it. You know, my left leg is a gift from my grandmother, and her varicose veins is very, very generous of her to me years after her death.
We have a quick back and forth here. Somebody asked how Tim, how were you diagnosed then? And Tim says CT at the ER. The tachy was scary, so I went to the ER, and thankfully a hospital that knew where to look. I think that's where you came in. Follow-up question from Epicurean. In terms of sartans, calcium channel blockers, and beta blockers, is there anything in there that they should look at?
I know they really want me to answer this question. Consult your physician, please. No, it's really,
That's what I wanted you to say.
It's going to be trial and error, and you're going to have to consult your doctor and talk to your physician about stuff. And the key is, you know, get a blood pressure medication. Oh, this is good. Validatebp.org. Validatebp.org. It's a website where a bunch of us got together and tested the blood pressure cuffs against the standard. You know, some of them are cheap, some of them are expensive. It doesn't matter. It's nothing to do with it. It's just we got to make sure that the blood pressure you're getting on the little machine is actually correct. Stop 5 minutes in the morning, wait, sit down, take your blood pressure 3 times. Again, do the same thing at night. Obviously, you don't get to pick. The highest blood pressure is the blood pressure, right? The reality of it is that the more information you bring to your physician, the better your physician will be able to treat you. So by all means, get a blood pressure cuff. Don't check it every hour. If you're one of those people, don't get a blood pressure cuff at all. But it would be nice if you could emotionally disconnect yourself and just do it twice a day, because that's the best way to do it.
Thank you, doctor. Back to you, Karen.
All right. I was just thinking about it. You were just going into, you almost did it. You almost got to explaining how it's one way to ace your healthcare journey. Advocate, communicate, and educate. Hey, did you hear we came up with a new one? We've been talking about it since August 30th. and how we basically spread awareness ASAP, because awareness saves aortas, period. Yes, that's a good one. All right, I think that is all that we have, and I think we got you right in.
Whoa. Real
by
quick,
5 o'clock.
real quick. One
Yeah.
just floated in. When you take BP, does it matter if it's left or right arm?
It's a good question. And I'm going to guess when he comes back, from what I was told, and we'll see if I was right or wrong, if you've had a dissection, you're going to take it on the arm that yields you the higher result. There are some people that for various reasons can't take it on certain arms, lymphoma, other issues like that. But if you can take it on either arm, whichever one gives the highest reading, that's the arm you stick with. That one will typically always read higher. And so for myself, that's my right arm. So for a while, I used to say, I'm going to take it on the left. And I would make myself feel mentally a lot better by going with the lower number. But the reality is, it really was the higher arm, the arm that produced the higher number. So that was what I had to go with. But we'll have Ben chime in on what the right answer
I think
is.
I remember that show when you got corrected on that too.
Yeah. And then there's also
was it your cardiologist? Was it her?
It was my cardiologist said that. Yeah. And I was like, oopsies, that was years ago. And I don't bother on the left arm, except I'm really feeling bad. I'll check the left against the right. And if it's like 25-point difference, I might make a quick phone call and tell somebody. And then there's also conversation about wrist cuffs versus arm cuffs. I am 100% an arm cuffed girl because I've heard a lot of people say that wrist cuffs, while they should be calibrated the same, sometimes aren't. And most of what you'll see on validatebp.org is going to be the arm cuffs. And, making sure that you're taking it in between the crook of your arm and your shoulder, that it's sitting right in the middle, and that you do have the tubing going down the arm right there in the center. So that's really important. And to make sure your legs aren't crossed, that you're not doing it right after eating, you're not doing it while watching Friday the 13th or having an argument, just comfortable, sit, give yourself a few minutes like Ben was mentioning, and then taking
You
it.
guys argue about Friday the 13th a lot, just in terms of cinematic.
No. Hey,
Just wondering if those are
what
those
we're
were-
arguing
if those
about
were
right
the
now
same
is
conversation.
there a specific arm you have to take it on?
If you've never had any surgery, the answer is no. If you have had surgery, the answer is maybe.
Right. I was told you take it on the one that's the highest, and that's the one you stick with. If you can, take it on either. I was right. Ding, ding. See, I do pay attention. I do learn things.
You do.
So, yeah. So that was an eye opener for me, having to therefore take a look at the higher number. It told me a lot.
I'm sorry. I have a little bit of an issue.
You're amazing. Thank you so much, as
It
always.
was a pleasure, you guys. Thank you so much. I'll see you all in New York City on the 27th of September.
Yes,
We're very much excited. And if I don't see you this year, I'll see you next year.
It's happening. All right, everybody. Once again, we thank Ben Youdelman for joining us. It's always such a blast to have you on the show. Please click like, please click subscribe. And again, we already have another live event coming up at 7 p.m. today with Terry interviewing Dr. Beaver. They're going to talk all about aortic valve disease. And hopefully I will be seeing you guys in about another week or so at the Bridge Walk, and look forward to it. Take care, everybody. Have a wonderful night. See ya.